Good morning, everyone. I'm going to start by thanking you for your patience. We've had a couple of technical glitches on our end that we are trying to work out, but we're going to jump in and start moving. So, good morning and welcome to Coffee with the Coalition, hosted by the Indiana Coalition Against Sexual Assault. My name is Kelly Gartland, and I'm the Director of Sexual Assault Response Programs here at ICASA. Before we get started, I'd like to go over how to participate in the event. Participants may view captioning by clicking on the Captions button at the bottom of your screen or under the More button. Next, click Show Subtitles to view captions at the bottom of your screen. So that we know who is in attendance today and we can call on anyone who asks questions, please be sure that your first and last name and pronouns are displayed in your name. To use the features needed for today's event, please hover over the bottom of the center of your screen and you'll see a series of icons. The mute button can be used to unmute your microphone when you are called upon. All lines are muted at this time. Please click on the chat button icon to open the text box to the right of your screen. During designated Q&A sessions, you may raise your hand to comment or enter your question in the chat box. The raise hand button can be located at the bottom of your screen under the More button. You can submit questions or comments for today's presenters in the chat box at any time during the presentation. Questions may be answered during the presentation or during the designated Q&A session. ICASA staff will be monitoring the chat box to help relay questions to the presenters. If you experience any technical issues during this call, please send a message to the chat box to Anesu or the info account, and a member of the ICASA team will assist you. The session may include triggering content. Please feel empowered to leave this session if you feel uncomfortable in any way. This session will be recorded. The recording will be available to participants through their original registration. If you need to leave the session for any reason, you will be able to view it again through the online learning platform. Once posted, ICASA staff will notify participants and provide instructions on how to access the material. At this point, I'm going to introduce Angie Morris, who is one of our presenters. We have two presenters today who are distinguished Thanes and also friends of ICASA. One of them is having some technical troubles, but I'm going to do both introductions today so that once she makes it in, we can keep rolling. So Angie Morris is employed by the University of Southern Indiana College of Nursing and Health Professions, where she works as the project coordinator of the Indiana SANE Training Project. The project provides medical forensic education to healthcare providers throughout the state of Indiana and works closely with stakeholders to improve the medical and legal outcomes for those who experience violence and abuse. Angie's educational background includes a bachelor's degree with concentrations in social and behavioral science, with minors in sociology and criminal justice from Indiana University, a bachelor's of science in nursing from Marian University, and a master's of science in nursing from the University of Southern Indiana. Angie has been in the field of nursing for more than 10 years and has experience as a forensic nurse examiner in the emergency department of a Metropolitan Level 1 trauma center. She holds 3 board certifications: sexual assault nurse examiner for adults and adolescents, a pediatric SANE, and a certified emergency nurse. She has provided medical forensic training, mentoring, and support to thousands of healthcare providers and multidisciplinary team members across the United States since the inception of the Indiana SANE Training Project in late 2018. Our other presenter today will be Ashley Smiley. Ashley completed her Bachelor's of Science in Psychology and Criminology with honors from Indiana State University in 2006 and furthered her education at Lakeview College of Nursing, completing her Bachelor's of Science in Nursing in 2010. Her nursing background includes health coaching, adult progressive care, adult med-surg, adult medical behavioral care, psychiatric care across the lifespan, and emergency services across the lifespan. In 2015, Ashley completed adult and adolescent and let me say that again. In 2015, Ashley completed her adult and adolescent and pediatric SANE training and began working as a forensic nurse in the emergency department of an Indianapolis Level 1 trauma center, with additional experience working in rural and community hospitals. She advanced her career with the Indiana Department of Health in 2019 as the state SANE coordinator. She is a dual board certified SANE for adult and adolescent populations and pediatric populations. In her current practice, Ashley utilizes outreach opportunities to bring awareness to the impacts of violence and the need for multidisciplinary approach to service. She trains new and forensic nurses, provides support and resources for forensic nursing practice, as well as provides technical assistance to develop and enhance medical forensic services in healthcare facilities throughout the state. Ashley continues to focus efforts on establishing collaborative opportunities with community partners and stakeholders in Indiana to increase services for individuals impacted by violence and improve outcomes for Hoosiers across the lifespan. So thank you very much, Angie, for the information that you and Ashley are going to offer today and for your constant partnership to us at ICASA. Angie and Ashley they are on speed dial for me. So we're just really pleased to hear from you today. Thank you.
Yes, thank you so much for having us. We are excited to be here. And we have a little presentation for you, but I am going to kind of motor through it just to leave you all enough time for questions and answers because I know that there are a lot of just things that you all probably would like clarification on. And sometimes today we might not have the answer, but we can provide kind of some suggestions as to our best path forward. And if there's anything I don't know the answer to, I can assure you that we will bring it back to a multidisciplinary team to talk through and get you a response that's going to be a victim-centered approach to ensuring that you guys get what you need. I'm going to work on trying to share my screen here. Bear with me just 1 second. And hopefully that is showing up for y'all. Okay. So this is a presentation from the Indiana Department of Health. So their mission is to promote, protect, and improve health and safety of all Hoosiers. I do not work for the Department of Health, but I'm giving you a little bit of their disclosure. I'm just making sure that you understand that the Department of Health and or our employers or organizations that we're affiliated with are not responsible for the things we say. I guess sometimes I'm controversial. I don't know. No. First and foremost, just so everybody's on the same page, the medical forensic examination should be conducted by individuals with specialized education and clinical experience. Primarily, what happens during that medical forensic examination is we do collect a medical forensic history, and that is a really fancy way of saying we get information from the patient about what happened. So that event, that is their symptom story. So, when you go to the doctor or when you go into the emergency department, we are very nosy. We are asking you questions about everything from the last time you ate and drank to the last time you had a bowel movement to, when did your symptoms start? What did you feel first? So this is their opportunity to tell us their symptom story. So a lot of that also does include events related to what happened during this incident. We want to have a very good understanding of what happened, what went where and when, because that information guides our medical care as well as treatment options that we have available to them. So it is very important that we have a comprehensive understanding of the history of the event so that we know how to approach their care. We will also do a head-to-toe physical examination and review of systems. We start literally at the head, work our way down to the toe, and then we do an anogenital examination and inspection last. Primarily, that is the last thing that we do because it's the most invasive. There are times where we will collect physical evidence. We will talk a little bit more about that in a few moments, but that can include swabs. It can include, in some cases, there's drug facilitated sexual assault, so it might include urine, and it might also include clothing. We will also document the biological and physical findings that we have during that assessment and evaluation. We will provide that patient with information, treatment, and referrals for not just their medical needs, but also for the biopsychosocial issues that they might be experiencing and provide for safety planning. So that is a lot of stuff. I will say that we do a lot of this with a team. So sometimes, depending on the facility, they'll be working with a social worker, they'll be working with an advocate on safety planning, they'll be working with a physician on certain things. So this is not necessarily all encompassing of everything that we do. Some patients are going to require diagnostic imaging, things like that, depending on what happened to them. But this is just kind of that broad overview of what they can expect in this examination. So when it comes to access to care, I want to make sure that everyone is on the same page, and this includes our healthcare providers, and we have attempted to kind of beat this into their heads, but we need your help and support on making sure that we are all in the same place. It is best practice for a survivor to be seen by a healthcare clinician that has been trained in providing this service. Those who are being seen by individuals who haven't been trained, we're just really concerned about the medical and the legal outcomes of what they might or might not be missing. So most commonly, they're going to see what's called a sexual assault nurse examiner. That is also known as a forensic nurse examiner. And that first priority of that sexual assault nurse or that forensic nurse is to address that patient's medical needs. Evidence collection is a secondary process. It's very important, but it should never be the deciding factor in whether or not a patient qualifies for services. And I hope that makes sense. So what that means is that, if you have a survivor that is beyond the time frame for evidence collection, but they continue to have medical concerns, or they're having post-assault symptoms, unhealed injury, pain, bleeding, mental health crisis, behavioral, physical well-being issues, those patients still need to be seen by someone who is trained in this field. While we are collecting evidence within certain timeframes, and I use that air quote because uh, we don't know what evidence, we don't know what is evidence until it is. So we can collect evidence up to 120 hours or 5 days post-assault, but there are times where we might see someone beyond that 120 hours or 5 days, and we may still collect evidence on them, both physical evidence, and we have to also remember that history, the incident history, is also evidence. So again, just because we're not collecting physical evidence, there is still potential for evidence to come out of these examinations based solely on the information that is provided in that medical forensic history. So I hope that kind of clears that up, but if not, let me know and we can revisit that here in a bit. Timeframes for that evidence collection. Again, this is that physical evidence piece of this. Primarily, we can collect vaginal evidence for up to 120 hours or 5 days. The research is showing bite marks, saliva on skin of around 96 hours or 4 days. Anal evidence potential for 72 hours or 3 days, and oral evidence for 24 hours or 1 day. Now, again, I don't want you to focus too much on the timeframes for evidence collection because we really don't want anyone to end up without services just because of a time frame issue. Because this is so much more than collecting evidence. And if you work with a sexual assault nurse or forensic nurse who tells you we do this for evidence, they are misguided. That is not why we do this. This is comprehensive medical forensic evaluation for all the reasons that I've already told you, and evidence is our secondary concern. So this is not our primary focus. While it's a big piece of what we do, this is not the only reason that our patients need to be seen by someone who has been trained in this field. So the value of the forensic nurse examiner or the sexual assault nurse is well beyond sexual assault patients. While that is the primary type of patient population that we see, we also take care of patients that have been impacted by domestic and interpersonal violence, traumatic injuries, especially in our trauma centers. So that would include gunshot wounds, stabbings, other penetrating injuries. One of the most horrific cases I worked ever was an animal bite. So we do take care of animal bites, psychiatric emergencies, vulnerable adult and child abuse injuries, work-related conditions, motor vehicle crashes, your drug and alcohol related, injury or illness, We do also, in some centers, take care of associate for causes. So what that means is if the leader suspects someone of drug diversion or being impaired on the job, that urine drug screen can be observed by the forensic nurse. Mass violence and casualty, drug and alcohol blood draws, especially post motor vehicle crash for law enforcement, and then suspect examinations, and those are done with a warrant. So it's a lot, especially in those larger trauma centers, in larger emergency departments, it's a lot more than the sexual assault patient, that they are seeing. Um, some information on CDC pregnancy prophylaxis. I just want to make sure that you all have this so that you have an understanding, of how to assist people in the best way while they're making a determination about whether or not they want an exam. So that pregnancy prophylaxis should happen as soon as possible. It is most effective when it happens early. So while we can give pregnancy prophylaxis for up to 72 hours, if that person is still trying to decide if they want to have an exam or if they want to report to law enforcement or whatever, this is going to be something that you might want to encourage them to consider sooner rather than later. When they come to the emergency department or are seen in a clinic, pregnancy testing is completed prior to giving that prophylaxis. We will do primarily a urine pregnancy test. Some places may do blood, or they may do blood as a confirmatory if we have a positive. So we also want to give those prophylactic medications. So primarily Plan B is a big one. Ella is one. We want to give those to patients of reproductive age. Adolescents who have not yet started their menses may still be at risk for pregnancy. So we really are going to assess their developmental appearance and their Tanner stage to determine whether or not pregnancy prophylaxis is indicated for them. But again, this drug needs to be given sooner rather than later. So if that's a conversation that comes up with advocacy, while we don't want you practicing medicine without a license, it is important for you to understand how these drugs work and the importance of taking them sooner. And again, these are things that are available as a part of that SANE exam, but they are also medications that are available over the counter too. So they can still get this at CVS or at Walgreens or whatever their local pharmacy is, if they need that pregnancy prophylaxis. The CDC also has sexually transmitted infection testing recommendations that some healthcare facilities will follow. And I'm just going to leave these here for you guys to have kind of an understanding of what we may test for. Now, there are some facilities that their policy and procedure is not to test the patient for STIs, but rather to treat them prophylactically for all STIs. And that's okay. So they might get some of these tests done during that medical forensic exam, or they might also just get medications and have the testing deferred, or maybe only be tested if they are symptomatic. Some of the baseline testing required prior to initiating that post-exposure prophylaxis for HIV medication, that is going to require an HIV rapid test. We also will do a pregnancy test prior to initiating that HIV medication, and Ashley will talk a little bit about that in a moment. We will do serum liver enzymes and a BUN and creatinine, just to make sure that their body functions are where they need to be and that they can support those medications on board. Some of the treatment recommendations from the CDC, and we provide these to you all so that you have an understanding of what the patient should have been given, so that you can help them understand if they've got coverage to their potential exposures. Ceftriaxone, doxycycline, and metronidazole are primarily the medications that we use. Sometimes due to allergies, we might change some things, but this is primarily the regimen that you will see with adult and your older adolescent female survivors. And then for adolescent and adult male survivors, we're looking at the ceftriaxone and doxycycline. And again, this is just so that you have some understanding of what should your survivors have been given, and if they did not get coverage for prophylaxis, that you can essentially help them find a location for that or get in touch with us so that we can re-educate on these departments if they need some updates. I'm going to turn it over to Ashley now, and she will talk a little bit about HIV prophylaxis.
So the HIV prophylaxis medications or PEP, those are typically used for patients that are screened as a moderate to high risk for transmission. And this is something that should be done for every single survivor that reports an assault. We want to make sure that we have fully assessed them, we understand their risk and what their potential is for that transmission, so we know how to best care for them going forward. But with PEP medication, there is a lot of confusion on how to access it, how to pay for it, what the medication should be, etc. So I know this comes up a lot, not just in the advocacy world, but it also comes up a lot in our healthcare providers. They just are either not assessing at all because they don't know what to do, or they don't have the medications available to give, or how to refer the patient for medications. Or they're doing it and it's just not, the patient's not following up and getting the medications or following through with taking the full regimen. So education is key when we provide PEP and when we do these risk assessments, so that everyone has the same understanding of what those next steps are, what they look like, and what it means for the person that will be taking, because these medications are pretty harsh on the body. I mean, they are trying to knock out a big virus. So it can cause a lot of side effects. But our main medications that we want to use are Truvada and Icentrus. Those are currently the recommendations by CDC. Trivacay is another one that's being utilized as well. So it really is provider preference. However, if it does not follow the CDC recommendation, we are basically practicing off-label for those medications that may or may not have been approved. Biktarvy is a big one right now that's being utilized for PEP, but it has not been approved by the FDA for that purpose. So it is an off-label use, and it may not be reimbursed by insurance. I know will not be reimbursed by ICJI. So we have to be careful on what medications are being utilized for this care. This is the chart provided by CDC. Again, that's something that we want to make sure that we're utilizing and following so that we can best care for these patients in the best way we know how. It is recommended that they be given within 72 hours of that exposure. Anything after that, 72 hours, limits the potential for efficacy of the medications in preventing the HIV transmission. It is also recommended that they take the full 28 days. If they stop early, whether it's after day 5 or day 27, the efficacy rate does go down, and we can't guarantee anything will be prevented. So we need to make sure that that full regimen is taken if it's prescribed. Okay, next slide. So this is the risk assessment kind of in brief that we have it's an algorithm that we have our providers go through to kind of evaluate, is this a potential for risk or not? Basically, if there was a vaginal or anal penetration, especially if there's injury or ejaculation, we want to make sure that that patient is is given PEP, or at least offered PEP and provided the education for the medication. Sometimes if there's an oral penetration without ejaculation or injury, if it's digital, we're not necessarily going to have that person take the PEP or recommend them for taking it unless they are insistent that they have it. We can kind of go over the risk and benefit of taking the medication, what it means for them, and what it is that they are really wanting and needing in that moment. Next slide. So accessing medications is hard at minimum. So when we talk about how to get these meds, we want to make sure that we are getting them paid for because they're very expensive. Truvada recently went generic, so that is great news for PEP reimbursement, because that means it's a whole lot cheaper. But just in general, these medications are pretty expensive. So, and we definitely don't want survivors paying out of pocket for them. We want to make sure that there is coverage for it, and we want to do it in the best means possible. So the manufacturers of these medications do have patient assistance programs, and we want to make sure that we're using them as much as possible because they're actually really good programs set up for these individuals. Now, if the patient has insurance, they will get a copay voucher, but it will be turned into their insurance. If they don't have insurance or their insurance doesn't qualify under that manufacturer's program, then they can get full funding assistance for the medication itself. So Truvada, that you get a voucher, you take it to the pharmacy, you have it filled. Icentress, they will actually mail an overnight package to a good address for the survivor, and they will get it the next day. So the important thing here is to make sure that you know how to apply for these. And generally, the healthcare provider should be assisting in that process and submitting those applications on behalf of the survivor themselves. But we want to make sure you guys know this process. So if you run into it, you may also be able to help and assist that process, or at least kind of guide them in the right direction to the right person to help them. Again, ICGI will provide Truvada and Icentress reimbursement, but we do want them to be the payer of last resort, meaning you know, if they have insurance, but they don't want to turn it in because it's their parents' insurance or it's their perpetrator's insurance, and they don't want that coming through on a bill or an invoice, then we can go ahead and use the ICGI voucher for that. If they don't have residency in our country or they don't have documentation, that's another opportunity to use ICGI. We want to make sure that they also get reimbursement for this. We do encourage our healthcare providers to at least give a 3 to 5 day supply of medications. That gives the patient enough time to get the prescriptions filled or the overnight medications mailed to them, but they have that buffer. Anymore, we're actually asking that these providers consider providing the full 28-day supply and reimbursing through their facility instead of going through the patient having to get the reimbursement or otherwise a voucher, because that way the patient has that medication in their hand when they leave. There's much more a higher amount of compliance when we do it this way. And we're seeing that throughout not just the state, but the country as well. It's just very difficult to get this process in place because, again, these medications are expensive. Pharmacies, whether they're in-house or a community pharmacy, they're reluctant to have these in stock because they're used so infrequently that they're afraid that they're going to expire and they're going to be eating those costs. Most of the manufacturers of these medications will replace unused medication vials that have been properly stored or unopened and giving, when they expire, to give them new medications. So that's another program that they have in place that is just not well known. Another option we have for reimbursement that I've been working with the HIV division at the Department of Health with is the community Walgreens. It's actually based in Indianapolis, but they do provide mail order medications throughout the state, and it is used for PrEP medications often. So we know Truvada and Icentress are a part of that program. So they are able and willing to also mail these out, the PEP medications, which are the same Truvada and Icentress, to patients. So we're working with them to come up with a clean process to make this as easy as possible for the survivor and their support system that's helping to get these medications for them. Next slide. These are the contacts for Truvada and Icentress, the manufacturers for both Gilead and Merck. This is how you would get to their applications for the PAP programs. This is just a resource. It's available to you guys. If you would like it, please reach out to me. I'll make sure that you have it, or you can kind of screenshot those as well. Next slide. This is just an algorithm that we put together to help providers and support systems to determine how to get these PEP medications paid for. Essentially just as a guideline, okay, if they have insurance, what do we do? If they don't have insurance, what do they do? Is it private or is it government insurance? Kind of thing. Again, we want ICGI to be the payer of last resort, but we also want to make sure that these are covered and patients do have access to them without any out-of-pocket expenses. Next slide. So we're talking about other reimbursements, examination, and the PEP medications. ICGI is our primary payer for the examinations. So it is actually illegal. It's a federal regulation that we cannot charge survivors of sexual assault for medical examination related to that assault. Any injury or medical conditions that are associated are covered. Now, during their assessment, if other things come up, other medical conditions that are not associated to the assault, during that same time that they're being seen for the assault, there may be a separate bill that goes to the survivor for those related costs. Now, it's a determination that the healthcare provider does have to make, and we have provided some technical assistance when it happens that the survivor gets a bill. So if there's ever any question, why is this person getting a bill? I thought this was reimbursed by ICGI. Please reach out to us because we want to make sure that it was done properly and that the bill that they're getting isn't for anything related to the assault itself. When we talk about reimbursement, the survivor should not ever get an initial bill. That reimbursement does go directly to the healthcare facility, and there's a process in place for them. Essentially, they're going to take the application that's filled out by the primary provider. They are going to get their documentation. So the narrative, any documentation of injury or assessment that they did for the examination, and then any other supporting documents with the invoice to ICGI, and that has to be completed within 180 days for consideration for that reimbursement. But essentially, it's the healthcare facility's responsibility to have that turned in on time with the appropriate documentation to support their application or request for reimbursement. It is not on the survivor to do that. Next slide. Excuse me. So when we're talking about those reimbursements, any adult 18 or older, they do have to sign for consent to ensure that ICGI can get the medical record, that it is okay for them to release the application to ICGI and all their records to ICGI for review. They do not have to report the sexual assault to law enforcement for reimbursement of a sexual assault. That sometimes is confusing because when we're talking about other types of violence in medical reimbursement, they do have to report. But just to be clear, for sexual assault, 18 and older do not have to report to law enforcement to get reimbursement for their medical expenses. Minors, on the other hand, they do. We do require in our state that law enforcement and the Department of Child Services be notified of the incident of the assault or abuse, along with the application that is filed and their medical records. A parent or guardian for that minor does have to sign release for that. But it's really not a choice for law enforcement and DCS to be brought in as part of that process. Next slide. So the Indiana Department of Health has recently released a map of Indiana that has all of our providers of medical forensic services in a locator. So that QR code, if you scan it, will take you to this resource. Essentially, you can type in any address and it'll bring up within whatever radius you decide providers in that area that can provide services. It will have the location of the provider, their contact information, and what services they provide, along with the populations that they serve. Now, this is in conjunction with the Indiana SANE Training Project. They do a quarterly request for facilities and providers to report to them if they're still providing services, where they're located, and what services they do provide. So this is based off that data that they are collecting. So we appreciate their partnership and being able to develop this map. It is public facing, so survivors, support persons, advocates, law enforcement, whomever. So you guys can access this information in real time. Next slide. We do request that if you're referring a patient or if you're a provider that is going to transfer a patient, that you contact the next facility that is nearby that's offering services to ensure that they have someone available to provide those services, so that the survivor is not bouncing from one facility to the next, trying to find someone to provide them care. So we just ask that you pull up that map, their contact information, and just give them a call. And they should either get you in touch with a charge nurse, or hopefully the forensic nurse that will be presenting to care for that person, so that you can talk with them just about their availability, when is, kind of how to get the patient there and things like that, what that process looks like for them. The SANE or the forensic nurse is going to be the best person to talk with about that so that they can give you a clear idea of what this process is going to look like, and it's clean and efficient for the patient. If it is a minor or there was a minor involved in the incident, so if it's an adult that had a child and they were present during the assault or they witnessed it, it is a mandatory report to the Department of Child Services and law enforcement. We just ask that you guys do your part as a mandatory reporter to ensure that those calls are made to the hotline at DCS. Next slide. So again, we were talking about kids. Anytime that they are suspected of abuse, neglect, or molest, it is important that DCS and law enforcement are contacted immediately. If the child was exposed or witnessed an assault or any type of violence, consideration should be made for those calls as well to DCS, just to ensure their welfare. Me, myself, I don't want to be the last person with that information and know that I could have done something and to ensure their safety. So, there's no punishment or consequence for making that call, even if it turns out to be unsubstantiated. You've done your part to notify someone that you were concerned about that child's safety. It's important not to discuss the details of the incident with the child. If you're talking with a parent or their guardian about the incident, whether they were directly or indirectly involved, please be respectful of those that are around you that can hear that information, and also asking direct questions to the child. It can impact how they recollect or how they are able or willing to share that information, and that can definitely impact their forensic interview. So we want to be cautious on how we talk to the kids when we learn of this information. If they are giving you a disclosure, don't stop them. Just don't ask any specific questions. Let them tell you what they're going to tell you, and just appreciate with them, how brave they were for sharing that. Thank them for sharing that with you. Anything you can recall that they shared with you, just try to write down. That way, if that information needs to be passed along, it can be. We want to make sure that our kids are seen the same as our adults. That 120-hour window for evidence is not a cutoff for a child to receive services. It may be for evidence collection, but we want to make sure that they still get set up with a trained professional or provider to get their examination. Even if it's non-acute, it can still be very valuable to that child and their well-being and outcomes in the future. Just remember that parents can't decline services, and they can't decline the Department of Child Services being involved when a child is impacted by violence, whether directly or indirectly. So it is, as a service provider, it is our duty to ensure that we're making those mandatory reports. We just want to make sure that we're providing education, that this is in the best interest of the safety for the parent and the child both. So making those calls is not punitive in nature. They are to be helpful to ensure the capacity of safety. And then just make sure that when a child is referred for services, that it is a trained forensic nurse or SANE or child abuse specialist. Next slide. All right, so we want to open up the remaining time that we have for questions, anything that we can clarify or any other information that you guys are interested in. Please feel free to use this time to ask. This is our contact information. So if you don't feel like this is the space for you to speak up or speak out, please reach out to us. We're happy to have those conversations with you privately as well.
Thank you, Angie and Ashley. You do have a couple of questions in the chat that I can point you towards or read them if that's helpful.
Do you just want to read them out and we can answer them? Would that be okay?
Sure. Yeah, that would be great. So you have one question: how can we advocate for more pharmacies? This question came in during your conversation about the HIV PEP meds. How can we advocate for more pharmacies, especially in rural areas, to carry these medications? And then a follow-up of, what do you suggest as viable options to clients who need STI and HIV testing, but no testing option is readily available in their county?
So to address the first question with pharmacies, this is just kind of an ongoing issue that it's not even just in rural communities, even our larger communities sometimes have trouble with pharmacies carrying these medications. Sometimes it's about education, just letting them know that there are options for, having these medications on hand if they're not utilized before expiration, which I believe is 2 years. Then there is an exchange program available to them through the manufacturer. That can sometimes be helpful. I know because of the cost, they're really reluctant to do that. But if there is a specific pharmacy or community that is needing some outreach, please contact me, and we can kind of work with our resources to see what we can do to get that going, and or at least finding someplace nearby that would be more accessible. If not, like I said, the community Walgreens is another option to getting those prescriptions to them and then mailed to the patient directly. Kelly, what was the second question? I kind of forgot. I'm sorry.
No, that's okay. Absolutely. Let me scroll up. So the
It
second
was
question
about
was,
STI testing.
yes, what do you suggest as viable options for clients who need STI or HIV testing, but no testing option is readily available in their county?
Um, so travel is always, always an option. It's not a feasible one. And we do know that. So we can, again, kind of the same thing as the pharmacies. If you reach out, we can try to locate the nearest location for them to receive those services. Local health departments will often do STI testing. If there's not another clinic, they may reach out to their local health department. They may also be able to help find referrals for primary care providers if they don't have a primary care provider. If not, that's something that we can try to do as far as locating those types of services within community-based clinics. But it really is just dependent on the community and the resources that are currently available. We can kind of help pinpoint those as well. Emma, do you have a question?
Yeah, so both of those were my questions that I put in the chat, and I just wanted to provide like a little bit more context or kind of what we're seeing here. So, I am located out of Fort Wayne, but I work for an agency that provides services to 6 counties, Allen County and everywhere surrounding. And so because of that, we work really closely with the Sexual Assault Treatment Center. They do all of our forensic examinations for, I think, like 16 or 18 counties, including all the ones that we serve. We have, though, run into a few difficulties, one being, so like if you take Wells County, for example, unfortunately, their OBGYN office closed and their health department is 2 people. So they do not offer any STI or HIV testing in-house. Right now, in order to access free testing for them, we actually have to bring them to the Allen County Health Department to have it processed there. And then further, what we're finding is with the medications, so with the HIV medications, there is only one pharmacy in Fort Wayne on the south side of Fort Wayne that carries it for all 6 of the counties that we serve. So again, it's just causing a barrier both for people in Fort Wayne, because Fort Wayne is large enough that only having one pharmacy carry it is, I mean, it's a big enough city, it is a stretch. But then like, especially for these outer county clients. And I can think of like one example, like specific example to provide you with a narrative. We had a woman who needed some help from us. She had gone to the Sexual Assault Treatment Center and gotten all of her initials done. But they needed her to get tested for HIV at a health department and then follow up with the medications. So in order to facilitate that happening, because her resources were so limited, we went out to Wells County, picked her up, transported her to the health department. No. We picked her up from the Sexual Assault Treatment Center, took her to the pharmacy, because the Sexual Assault Treatment Center automatically puts the meds into the pharmacy. So then we drove her to the pharmacy that day, which is on the opposite end of town from the Sexual Assault Treatment Center. When we got there, only one of the two medications was ready or available. They only had one that she needed that day. So we took that one, we took her and then dropped her back off at home in Wells County. Then the following day, we had to go to the pharmacy and pick up the medication and take it out to her in Wells County. And then we had to go pick her up and take her to the Allen County Health Department for a follow-up HIV test and then take her back home after that. So it created a lot of, and this client had no means to transport herself, and none of our public transport goes over county lines or really outside of the city for that matter. So it created a whole lot of back and forth, a whole lot of resources and times being spent where it feels like these should be things that are more easy to access in a closer way. Because when all was said and done, we had spent, I think, over 12 hours just in the car. Like,
Right. Yeah.
So, Emma, this is Angie. I think that this is exactly a situation that we need to use the PEP programs for, because that could have been a situation where those medications were sent directly to her home and none of this extra stuff would have been needed. I mean, she may have needed that initial HIV test, but it could have stopped there. So I think that's something that maybe Ashley can look into on the back end with the nursing staff to ensure that they're even aware of how to use that patient support program and who is qualified for it. But I think in the meantime, if you run into those situations, if you could send Ashley a message with the details and the facility that prescribed the medication, that would be really helpful for us to know, just so that we can um, re-engage with those facilities to make sure that we're all on the same page about what this could look like and how to make it easier for everyone involved.
okay, great.
Jamie, did you have a question or a comment that you wanted to share?
Yeah, I have a question. Can you hear me?
Yeah.
Yes.
Yeah.
Okay. I was wondering like how you recommend minimizing like survivors having to retell like their story over and over in the hospital.
So, Angie, do you want to take this
That's
one?
why we recommend that they're seen by a sexual assault nurse. We know that this happens. Unfortunately, we try to encourage all of these programs to have an understanding that if you have a sexual assault nurse on site, please do not have anyone else in the ER ask about the history. That can be given to the nurse, and that nurse can then discuss with the provider. Primarily, when I say provider, the doctor that's overseeing the care, this is what happened, this is what went where and when, and these are the medical indications that they have. Most of the facilities who do have sexual assault nurse programs that are consistently running and running well kind of know not to ask about that, because they don't also want to be brought in as a witness. And because that is potential. If you're asking information about this, you could potentially be brought in as a fact witness. And if you talk to your physicians about that, they're like, whoa, wait, what? Because they don't want to be brought in. So a lot of it is just re-educating the nurse examiner programs to remind their healthcare providers that we don't need to be asking questions. If you have questions about what happened because it matters to your medical care, then the nurse can have a chat with the doctor about the details. That's our best option. And again, if it's the same facility that keeps doing it over and over again, if you could let us know where that is, um, we can help facilitate those conversations with their emergency department leaders and their physician groups, because yeah, we don't want that happening.
Is there something like a good way to approach it as an advocate to say something to the hospitals or the nurses or
Um,
registration?
Oh, you mean like in real time?
Yeah. So like if it's being done, like is there anything that you recommend advocates, like a way to like approach it and be like, hey, uh, they've already like
Yeah,
without causing any
yeah.
sort of
Yeah, I know. It's a really sensitive issue. I mean, I think it's always better if we could kind of correct or have the conversation without the patient sitting right there. But just kind of prompting, hey, she's already given the details of this. If we could refrain from asking about this again, it seems to be causing additional stress, and we know that it's not trauma informed to continue to ask these questions over and over again. I don't really know why a registration person would be asking details outside of when it happened, which again, registration can be encouraged to just talk to the nurse because the nurse is going to have all of those details. If you need to know what day it happened, I can tell you. I think that's the other question, the other thing that is good for each facility to know, like, what are the details that your registrar needs to get them registered so that the nurse can go ahead and just make a note of that information, pass that along to registrars so they can get them registered without having to go back through this. Physicians, it's hit or miss. And, you know, it's one of those things that the patient does have the option of declining talking about this again. And so that could be something that maybe you talk with the patient, like if someone else comes in and asks about the history, and you look very worn out, like we don't want to talk about this anymore. You have the right to say, I've already told my story. Please check in with the nurse. This is too much. So that will redirect that person to hopefully go back to the healthcare provider who did collect that medical forensic history because yeah, it's a tricky one. But again, if there are facilities that are specifically not doing this in the most patient-centered way, if you could let Ashley know who those facilities are, she can certainly have a conversation to work towards resolution to make it more trauma informed.
Okay. Thank you.
There was a question real quick in the chat about anonymous kits. So I just wanted to clarify some information because there seems to be some dialogue around that. So just know that each jurisdiction has an option to handle anonymous kits differently, but there is kind of a standard that should be followed. Essentially, the survivor's name should not be shared outside of the healthcare facility. If they are going to be anonymous or not reporting, that information should not be on their kit, but they still will get a serial number and a PIN number to track in the kit tracking system. Law enforcement will not be contacted for a report, but they are still responsible for picking up that kit and storing it. So whatever agency has jurisdiction over where the assault took place will be contacted by the healthcare facility to pick the kit up. But like I said, it should not have any information, any identifying information on the chain of custody or the kit itself. So how that is stored is still up to that law enforcement agency and for how long, but it is up to it for at least a minimum of 1 year. It may be stored longer, but like I said, we don't know. It's based on that jurisdiction or that agency on how long they do store it. If the person changes their mind, they can go to law enforcement and let them know that they had an exam done. They will need to know where the exam was done, what facility, the date they received services, so that when law enforcement is able to or needing to get that information, that record, or find the kit, then they have a reference to when they call healthcare. They will also need a signed release of information from that survivor in order to get that information from the healthcare system. So what that process looks like depends on the agency and the community where, or the facility where that took place. But we can provide assistance for developing that process. And there will be some additional information on anonymous kits and non-reporting kits coming from the state SART committee soon. So we will make sure to notify you guys when that is released. Emma, did you have a question?
Yeah. So I just wanted to ask for a minute because I know right now, in General Assembly, there's a bill about addressing the backlog of rape kits here in Indiana. I was just wondering, like, are you guys anticipating an outcome on that bill? If so, what's the outcome? And if it gets passed, is there a plan of what to do with all of the John Doe and Jane Doe kits that currently exist in that backlog? Yeah, Beth, I was like, I know you might want to chime in here.
I'm here. I've been listening, and yeah. So yes, Emma and everyone else, we do have more than one bill actually addressing the backlog. Frankly, surprisingly, one of them is getting a hearing this week on Thursday morning. I plan to be there to testify. I was surprised to see it get a hearing, frankly, because it does carry a fiscal associated with it. It calls for 2.5 million, which, by the way, is nowhere near enough. But the money would directly go to the state lab, which is, well, I haven't talked to the lab director. I am surprised, as I said, it's getting a hearing. We are in very early days, very early days. And what I would say to your question, Emma, is that we should all stay tuned. And what I know about the legislative process is that it is not a great use of energy to try to talk about implementation and execution on legislation until we are in much, much later days, as far as what we expect. But I'm hopeful because I think that there seems to be some real meaningful attention given to this issue. And when we see this bill continue moving or other bills like it moving, I will be working with our partners to develop more concrete plans. But right now it's too early for plans. So, and I'm over there and I'm paying very close attention to everything that's been filed and what's getting hearings. So thanks for the question. Thanks, ladies. Sorry to jump in and derail your presentation, but Ashley and Angie and I have lunch once a month and we talk a fair bit about legislation. And it's an adventure every single day.
Thanks, Beth. We appreciate your input. Any other questions or concerns that we can address before we close out?
Beth, there's a question in the chat of what time the hearing is Thursday. Do you happen to know that time off the top of your head?
I do. It is at 8:30 in the Veterans and Public Safety Committee in the House, which I think is somewhat strange, but it's in the basement on the House side of the State House in room 156B, I think. I plan to be there, as I said. I don't necessarily think it's the best use of time for people within our network to attend the hearing. But if anybody is interested, please reach out to me at beth@ikesaht.org. And I'm happy to talk with you or anyone else about what's going to happen at the hearing Thursday morning at 8:30 on the House side of the basement. It's the first floor at the State House.
I have received one question that I would like to share, if that's okay with you.
Yeah, of
So the
course.
question is, if a victim is seen at an initial facility and that initial facility does not offer HIV testing or PEP treatment, so that victim drives to a different county for HIV testing and treatment. If that victim is at the second facility, would ICJI still be able to cover the services and billing for that second facility if the form is filled out?
So the answer is they should. How this is done can be a little bit tricky. So essentially what will need to happen is if facility A completes the application to submit for reimbursement to ICJI, facility B will need to know, they essentially will need a copy of that application to also submit for they don't need a new application. They need the initial one, but to also notify ICJI that additional services were received from their facility. Clear as
Okay,
mud.
But can we go one step further to eliminate this from happening at all? Why is the patient going from facility A to facility B for something that facility A should be offering?
Hi,
Do we-
I'm Okay, I'll just get on here and ask and have this conversation. My name is Brianne Turner, and I work at Marion Health in Marion, Indiana. And so we have had a phone call recently from some victim or a victim service provider who said something about like the victim was going to need all of this done, but there was this runaround of who can test and then who can also treat and prescribe the medications. And it was more of like a prescription needing to be written issue. Now, I'm not for sure of the exact details of everything that had happened during this case, but my provider had gotten involved at the hospital and was concerned that there were sending these victims to different counties to get tested, but then there was nobody to prescribe the medications. At our facility, my providers are 100% okay prescribing the medications if they're needed, but there was some concern about, well, would that come back on us? Then would they get a bill from RER then, or would that have to go to the ICJI or whatever that looked like?
So to be clear, anyone with prescribing licensure is able to prescribe PEP medication. There's not a restriction on a prescriber's ability to do that. So it's more an act of want or understanding of what that looks like. They may not know what or how to prescribe that medication. So if we know who that facility is, it would be easier to address it that way. Now, if it's a nurse and they should still have a prescriber available to write those prescriptions for the patient. So for example, so when you fill out the patient assistance program application for PEP medications, essentially you just need to have a prescriber sign that, and it becomes the prescription to that manufacturer, and then they can in turn mail that back to the patient. So if you're a nurse practitioner, a physician's assistant, a DO, or an MD, they can all sign that as prescribers. So I think there's just some misinformation or misunderstanding of what that looks like that we are happy to help address to prevent this from happening, because it complicates, one, the billing to ICJI, but two, it is very complicated for the patient to try to render these services from one place to another in hopes that the second place is going to see them for their needs and not send them somewhere else. I'll be honest, we've seen it happen to where they've seen 3, 4, 5 places before they actually get services. And by that time, it can be too late.
There are clinical guidance tools available too through the CDC for the healthcare providers as well. So, there are several ways that your physicians or prescribers have to kind of figure out what should be happening. We're also a phone call away. Obviously, we're daytime hours, but yeah, that's unfortunate. And I think if we can just get to the facility and have that conversation, re-educate them on what should be happening and what the actual medications should be prescribed, I think that could be helpful in eliminating that second visit, because there's no reason to defer that care when you have someone who has prescriptive authority. So I don't know why that would happen.
Okay, I'll send you both an email with maybe a little bit more information on it, to not take up extra time today, but that way you can kind of get a loop of what's going on.
Awesome. Thank you. Yeah.
I'm also going to put in the chat, the clinician to clinician, oh my gosh, website. Sorry, I'm multitasking. It's not working well. So that's the website they can go to get the hotline number and additional clinical resources for this process. So that may be helpful too, to share with your own providers. But if you have peers or colleagues in other healthcare networks, you can share that information to as a resource for them as well.